This recorded lecture will be going over Chapter 29, Care of Patients with Disorders of the Lower Gastrointestinal System. Whenever illness or diet and activity changes occur, bowel motility is affected. Medications for symptom control for diarrhea or constipation will be prescribed according to the patient's symptoms. Drugs that have been used include bulk forming agents, antidiarrheals, antispasmodics, antidepressants, anticholinergics or sedatives, and mild analgesics to relieve discomfort. A diet high in fiber may also be prescribed. Bulk forming agents like Metamucil or stool softeners are recommended. Gas forming foods like legumes and those in the cabbage family should be avoided. Wearing loose clothing is more comfortable if bloating or increased abdominal pressure occurs. Irritable bowel syndrome, or IBS, is a functional disorder of GI motility. In North America, IBS is far more common in women than in men. The cause of IBS is unknown, but it is thought to result from a hypersensitivity of the bowel wall that leads to disruption of the normal function of the intestinal muscles. Stress, caffeine, and sensitivity to certain foods like dairy and wheat products will seem to trigger IBS in some people. IBS can occur after a bowel infection, possibly related to changes in intestinal cells and normal GI flora. There is evidence that with IBS, there is an abnormality of nerve function in the intestine. On page 688 in table 29.1, you can see some drugs commonly used to treat GI disorders. IBS is a group of symptoms that together represent the most common disorder in patients who consult gastroenterologists. The three characteristics typical of this disorder are alteration in bowel elimination, which is either constipation or diarrhea or both, abdominal pain and bloating, and the absence of detectable organic disease. Diagnosis of IBS is based on clinical manifestations and ruling out the presence of organic bowel disease. Diagnostic criteria includes abdominal pain or discomfort that is either relieved by defecation or associated with a change in stool frequency and/or consistency, mucorrhea, which is mucus in the stool, and abdominal bloating. IBS is treated symptomatically to control the diarrhea or constipation experienced. These patients will need reassurance and support. Gluten intolerance has been identified as a possible trigger for IBS symptoms. Therefore, patients should eat foods like white rice and lean poultry. Randomized controlled trials have shown that cognitive therapy, psychotherapy, and hypnotherapy have helped improve overall symptoms. The term diverticulum refers to a small, blind pouch resulting from a protrusion of the mucous membranes of a hollow organ through weakened areas of the organ's muscular wall. Diverticula are most prevalent in older adults and occur anywhere in the intestinal tract, but are found primarily in the colon. When diverticula are present, the patient is said to have diverticulosis. This is uncommon in patients younger than 50 years and almost universal in those older than 90 years. Increases in intra-abdominal pressure from constipation and straining to defecate, obesity, and a low-fiber diet all appear to be factors in the development of colon diverticula. Diverticulitis will occur when the diverticula become inflamed or infected. This occurs in about 20% of those affected by diverticulosis. The intestinal wall can become infected, and if not treated, perforation and peritonitis can occur. Esophageal diverticula occur when there is herniation of esophageal mucosa and submucosa into the surrounding tissue. This disorder is more common in older patients. A person with diverticulosis may initially be asymptomatic. However, symptoms will develop when the inflammation or infection occurs, because the material has lodged itself in the diverticula. There could be rectal bleeding. Diverticulitis of the intestine will produce symptoms of diarrhea or constipation, acute left lower abdominal pain, bloating, nausea, and vomiting. This condition can be complicated by intestinal obstruction or by peritonitis if the intestinal wall ruptures. CT of the abdomen with water-soluble colonic contrast is the preferred diagnostic test. Esophageal diverticula will produce symptoms of dysphagia, regurgitation, nocturnal cough, and halitosis. There is also a risk of esophageal perforation. Diverticulosis often can be managed conservatively. A high-fiber diet, increased fluids and bulk laxatives, or stool softeners to control constipation may be all that are needed. For acute, uncomplicated diverticulitis, outpatient treatment can include clear liquids for 2 to 3 days with oral antibiotics. The role of the LPN is to reinforce education about the diet, fluid intake, and exercise. In acute complicated cases of diverticulitis or with failed outpatient treatment, parenteral antibiotics with IV hydration and bowel rest by placing the patient on an NPO status for 2 to 3 days may be necessary. Recurrent episodes of diverticulitis or perforation and peritonitis will require surgical treatment. Perforation requires an emergency surgical intervention. The type of surgery performed and the approach will be determined by the reason for the surgery. In some cases, a temporary colostomy may be needed to allow these tissues to heal before reconnection. In other situations, the colostomy may be permanent. Intestinal obstruction is a sudden or gradual blockage of the intestinal tract that prevents the normal passage of GI contents through the intestines. Mechanical obstruction results in blockage of the lumen of the bowel. Examples include tumors, adhesions, strangulated hernia, twisting of the bowel, known as volvulus, telescoping of one part of the bowel into itself, known as intussusception, barium impaction, foreign bodies, and adhesions. Abdominal adhesions are a common cause of intestinal obstruction. Non-mechanical obstruction will result from the absence of peristaltis. Non-mechanical obstructions may occur as a result of paralytic ileus. This is failure of forward movement of the bowel contents, and it can occur after abdominal surgery or due to infection or hypokalemia. When obstruction occurs, fluid and gas will accumulate in the intestine, increasing the intraluminal pressure. Peristaltic waves can cause severe pain. The symptoms of intestinal obstruction vary according to the location of the obstruction. Obstructions occurring high in the intestinal tract are characterized by sharp, brief pains in the upper abdomen. Frequent high-pitched bowel sounds will be heard above the point of obstruction, and bowel sounds will be absent below the obstruction. Other symptoms will include vomiting with rapid dehydration and only slight abdominal distension. An acute intestinal obstruction in the upper abdomen can cause respiratory difficulty due to the pressure of the distended abdomen against the diaphragm. Obstructions of the colon are characterized by a more gradual onset, with marked abdominal distension as the bowel fills, possible vomiting, and pains that last several minutes or longer that will correspond to peristaltic waves. Fecal odor or material in the emesis will suggest a complete intestinal obstruction. Abdominal radiographs will be ordered to locate this obstruction. Insertion of an NG tube can relieve symptoms by decompressing or removing gas, intestinal contents, and mucus. Surgery is indicated for obstruction caused by adhesions, volvulus, hernia, or tumor. These adhesions will be lysed or broken apart, a volvulus untwisted, or a colectomy may be necessary if a tumor is involved. Placing the patient in a Fowler position will help relieve pressure and aid in removing the gas and intestinal contents through the intestinal tube. Measure abdominal girth every 2 to 4 hours by placing the tape at the same location on the abdomen every time. Pain control is essential, but worsening pain can signal an unresolved intestinal obstruction that could lead to rupture of the intestine, peritonitis, shock, and death. If there is a defect in the muscular wall of the abdomen, the intestine can break through the defect. This protrusion is known as a hernia or a rupture. The most common locations for hernia include areas where the abdominal wall is normally weaker and more likely to allow a segment of the intestine to protrude. These would include the center of the abdomen at the site of the umbilicus and the lower abdomen at points where the inguinal ring and the femoral canal begin. Hernias will be identified by their location. Hernias can be congenital or acquired. An acquired hernia may form at any old abdominal surgical incision, known as an incisional hernia. The most common contributing factors in the development of a hernia include straining to lift heavy objects, chronic cough, straining to void or pass stool, and ascites. Hernias are classified as reducible, in which the protruding organ can be returned to its proper place by pressing on the organ, and irreducible or incarcerated. This is where the protruding part of the organ is tightly wedged outside the cavity and it cannot be pushed back through the opening. If the protruding part of the organ is not replaced and its blood supply is cut off, the hernia is then considered strangulated or incarcerated, and this requires prompt medical attention. If the hernia is not incarcerated, there will just be an abdominal pouching or a lump or local swelling that comes out from the abdominal wall or in the groin area. Lifting heavy objects, coughing, or any activity that puts a strain on the abdominal muscles could force the organ back through the opening and the swelling will reappear. Pain occurs when the peritoneum becomes irritated or when the hernia is incarcerated or strangulated. The flow of intestinal contents can be blocked by an incarcerated hernia, leading to symptoms of intestinal obstruction. This is an emergency because when the blood supply is restricted, part of the intestine may die. The surgical procedure used in the treatment of a hernia is called a herniorrhaphy. If the area of weakness is very large, a hernioplasty can be done. In this procedure, some type of strong synthetic material will be sewn over the defect to reinforce the area. The material used is a mesh product. It does have potential for complications because a foreign object is being implanted. This procedure can be done on an outpatient basis or as an open or laparoscopic procedure. If surgery is not possible due to age or high surgical risk, the patient can be fitted with an appliance called a truss. This reinforces the weakened cavity wall and prevents protrusion of the intestines. This is only a symptomatic measure and it will not cure the hernia. Care after hernia repair is directed at pain control and preventing recurrence of the hernia. Guidelines on signs and symptoms of complications will be sent home with the patient, along with a written list of activities that they must avoid until healing is complete. Lifting restrictions are typically implemented for 1 to 2 weeks, and the patient will be instructed to support the site with the hand when coughing or sneezing. Bowel ischemia occurs when the blood supply to the bowel is insufficient to support metabolic needs. This can be an acute process or a chronic condition. Ischemia can occur as the result of bowel obstruction or as the result of hypovolemic shock. In 95% of chronic conditions, diffuse atherosclerotic disease of the mesenteric vessels is the source of decreased blood flow. This is known as chronic mesenteric ischemia, or CMI, and it is a rare diagnosis. Most episodes of bowel ischemia will result from an acute event. Acute mesenteric ischemia can result from arterial emboli or thrombosis. Acute events not involving the obstruction of blood flow would include those that decrease the blood flow, like hypotension, sepsis, or severe liver or renal disease. The sudden onset of severe abdominal pain signals an acute condition. Nausea, vomiting, diarrhea, and abdominal cramps can also be present. The abdomen is tender to palpation, and the patient will exhibit guarding. The bowel sounds will be minimal or absent. CT angiography or magnetic resonance angiography or MRA can be used to confirm this medical diagnosis. The patient will be NPO and an NG tube will be inserted to relieve distension. Ischemia from an obstructive cause, either thrombus or embolus, can be treated with intra-arterial infusions of a vascular smooth muscle relaxant at the site of the blockage, or thrombolytic therapy can be used. The standard treatment is IV heparin. Inflammatory bowel disease, or IBD, includes both ulcerative colitis, known as UC, and Crohn's disease. UC is an inflammation with formation of ulcers in the mucosa of the colon. It is almost always involving the rectum, and it will extend up into the colon in a continuous manner. Crohn's disease is a chronic inflammatory disease that involves all layers of intestinal tissue, and it can involve any part of the GI tract. It most commonly affects the distal ileum and proximal colon. Both of these diseases are idiopathic. Crohn's disease and UC have a genetic predisposition. UC is 3 times more common than Crohn's disease. Both of these disorders also have an ethnic correlation. They are more common among the Jewish population. Smoking will increase the risk of Crohn's disease, but not for UC. It is suspected that UC and Crohn's disease are immunologic responses to the same, yet unknown, etiologic agent. The result is inflammation of the mucosal lining of the intestinal tract, causing ulceration, edema, bleeding, and fluid and electrolyte loss. UC and Crohn's disease share many of the same characteristics. One main difference is that the inflammatory changes in UC are nonspecific, whereas those in Crohn's disease are granulomatomus. This means a mass or inflamed tissue characterized by the presence of small granules. Changes caused by UC will tend to be continuous along the affected portion of the bowel, whereas changes caused by Crohn's disease are segmental, leaving healthy sections of bowel in between the diseased portions. We call these skip lesions. With Crohn's disease, radiography will reveal a cobblestoned appearance to the mucosa. Patients with IBD will have attacks of diarrhea that can be bloody and contain mucus, abdominal pain with cramping, malaise, fever, and weight loss. Bloody stools are most often found in UC rather than in Crohn's disease. The blood will tend to be redder when the bleeding location is lower in the intestine. The bouts of IBD symptoms are often precipitated by events that cause physical or emotional stress. An acute attack could last for days, weeks, or even months, followed by periods of remission extending from a few weeks to several decades. Medical diagnosis of IBD is typically based on the patient's medical history and symptoms. Colonoscopy, flexible sigmoidoscopy, mucosal biopsy, barium enema, and stool analysis can all be performed to confirm the diagnosis. On page 696, within table 29.2, you can see the comparison of ulcerative colitis and Crohn's disease. You can also see a visual representation of this on page 696. Treatment for UC and Crohn's disease will vary according to the severity and frequency of symptoms. Conservative approaches to medical treatment include administration of antidiarrheal drugs, long-term sulfasalazine therapy, and medications to relieve abdominal cramps. The recommended diet will consist of low-fat, low-fiber foods that are high in protein and calories. Small, frequent feedings are best. Medication therapy for Crohn's disease includes a biologic agent known as a tumor necrosis factor inhibitor with another drug to alter the immune response, typically azathioprine or methotrexate. Infliximab is a monoclonal antibody against tumor necrosis factor that has a greater than 80% response rate for Crohn's disease, but only a 50% success rate with UC. Surgical intervention is an alternative treatment for some patients. The surgical procedure typically involves removing the affected portion of the bowel, often by proctocolectomy, and then creating an ileostomy. The patient with UC could be a candidate for an ileal reservoir or a cock pouch, or an ileoanal anastomosis rather than a standard ileostomy. These procedures are not usually performed for Crohn's disease because this disease will progress and the area of the reservoir eventually becomes involved. For an acute attack of IBD, care will include monitoring the number and character of stools, periodic auscultation of bowel sounds, measurement of intake and output, and a daily weight measurement. Indicators of successful therapy include a decrease in abdominal cramping and discomfort and the return of a typical bowel pattern. Appendicitis is an inflammation of the appendix, which is a blind pouch, and it is therefore easily infected by bacteria passing through the intestinal tract. Obstruction of the opening into the appendix will trap fecal material, causing the inflammation. Pain in the lower right side, halfway between the umbilicus and the crest of the ilium at McBurney's point, is best known symptom of appendicitis. This is typically accompanied by muscle guarding. Extending the leg will cause pain. A slight temperature elevation, nausea, vomiting, and an increase in the white blood cell count are also characteristic of appendicitis. IV contrast enhanced CT scan or ultrasound will be used for diagnosis. Appendicitis is treated surgically by removing the appendix, known as an appendectomy. Patients with a non-perforated appendicitis should have surgery within 24 hours of diagnosis. If the infection is widespread or the appendix has ruptured, immediate surgical intervention is indicated. Under no circumstances should laxatives be given when appendicitis is suspected due to the increased risk for rupture. The patient is usually encouraged to be out of bed within several hours of surgery if there have been no complications. Assess for nausea, determine the pain level, take vital signs, and check the abdomen for rigidity that could indicate a ruptured appendix. Preoperatively, pain is the primary concern, and you will monitor closely for any signs of rupture. Postoperatively, pain control, mobility, and prevention of infection at the surgical site are the nursing priorities. Peritonitis is an inflammation of the peritoneum. This typically occurs when one of the organs it encloses ruptures or is perforated so that the organ's contents, excluding the bacteria, are then spilled into the abdominal cavity. Patients receiving peritoneal dialysis are at a constant risk of developing peritonitis from pathogens entering the abdominal cavity via the dialysis catheter. Normal peristaltic action of the intestines will slow or cease, and symptoms of paralytic ileus occur. The patient experiences nausea, vomiting, and severe abdominal pain and distension. Fever, chills, tachycardia, and pallor occur, and other symptoms of shock can emerge if sepsis is present. Unless the condition is treated promptly and successfully, peritonitis can be fatal. Early diagnosis and prompt treatment with antibiotics have improved survival rates for peritonitis. Diagnosis of peritonitis is by history, serum antibody assays, physical examination, and results of a complete blood cell count. Broad-spectrum antibiotics will be given IV fluids and electrolytes administered to restore a normal balance, and gastric or intestinal decompression will be initiated to relieve distension. Surgical procedures are needed to repair a ruptured organ, and this is performed as soon as the patient's condition will permit. Frequent assessment and prompt and accurate reporting of any unexpected changes in condition will be required. If vomiting occurs, the characteristic and amount of the vomitus should be noted. Pain management is also important because this is one of the primary presenting symptoms. A common complication of peritonitis is paralytic ileus. Therefore, auscultate the vowel sounds at least once per shift for the return of those sounds. High fever and toxicity that accompany peritonitis could cause the patient to become disoriented. Therefore, they must be protected from self-injury. The patient should be turned very gently and moved in the bed with care due to the extreme tenderness in the abdominal region. Many disorders interfere with the normal absorption of nutrients, water, and vitamins from the intestine. Adult celiac disease, also known as SPRU, in which the patient cannot properly metabolize gluten, is one cause of this. Lactose intolerance is another cause because it results in diarrhea. Whatever the cause, malabsorption will create a nutritional deficiency. A key sign of fat malabsorption is steatorrhea. This is the passage of stool that is bulky, frothy, and foul-smelling, and it typically floats in the toilet. Other signs and symptoms include weight loss, weakness, and various signs of vitamin deficiency, depending on the type of malabsorption the patient is experiencing. Diagnosis is made by history, serum antibody assays, upper and lower GI series, and endoscopy with biopsy. Treatment is directed at the underlying cause. Celiac disease is treated by completely omitting gluten from the diet. Lactase enzyme preparations are available over the counter and can relieve symptoms in some patients. Nursing management will consist of supporting the patient through the diagnostic process and reinforcing teaching about diet and medications. Cancer of the large intestine, also known as colorectal cancer, is the third most common malignancy in both men and women in the United States. Colorectal cancer is one of the most preventable and curable of all cancers if it is found in the early stages, and mortality rates have fallen over the past 30 years as detection has become easier. The disease mainly occurs in people older than 50 years, although there is a type that can occur in younger people. People the most at risk would include those with disorders of the intestinal tract, especially UC and inherited family cancer syndromes. Additional risk factors include smoking, alcohol consumption, physical inactivity, obesity, and a diet high in saturated fat and/or red meat, as well as an inadequate intake of fruits and vegetables. In the early stages, symptoms will be typically mild and vague. They also depend on the location of the tumor and the function of the affected area. Weight loss could be the first sign. Later signs of colorectal cancer are the result of obstruction of the bowel and extension of the growth to adjacent structures. Any change in bowel habits, either diarrhea or constipation, could be a sign of colon cancer. Other symptoms would include red blood in the stool, black tarry stools, changes in stool shape, appearing as a ribbon-like stool, abdominal distension without weight gain, sensation of incomplete evacuation after a bowel movement, and anemia resulting from intestinal bleeding. Screening tests will include an annual stool guaiac test, or a fecal immunochemical test, or stool DNA test. Beginning at age 45, flexible sigmoidoscopy is recommended every 5 years, a colonoscopy every 10 years, double contrast barium X-ray every 5 years, or a CT colonography every 5 years. A colonoscopy will be recommended if any of the above screening tests are positive. If adenomatous polyps are discovered early and removed, colon cancer can be prevented. Treatment of colorectal cancer will typically involve the surgical removal of the affected portion of the intestine. Reconnection of the remaining intestine portions will be done if the lesion is small and localized, known as a hemicolectomy. Larger tumors will be treated by excising the affected portion of the colon. Occasionally, a surgically created opening for the abdomen, known as a colostomy, will be needed to provide for elimination of fecal matter. A permanent colostomy is rarely needed for cancer of the colon. After healing takes place, the colon can be reconnected. Colectomy is the removal of the diseased portion of the colon. The remaining ends of the colon can be reattached. A hemicolectomy is removal of one side of the colon. Abdominal perineal resection is performed for cancer in the rectum or low sigmoid colon. This is an extensive surgical procedure in which part of the colon and the entire rectum, anus, and regional lymph nodes are removed. A permanent colostomy will be necessary. Preoperative, intraoperative, or postoperative radiation and chemotherapy can be given for cancer of the rectum. Use of radiation or chemotherapy for colon cancer will depend on the stage of the tumor and the presence of metastasis. Bevacizumab is an anti-angiogenesis medication that reduces blood flow to the growing tumor cells and deprives them of their nutrients needed for replication. You should determine the amount of alcohol consumption and the degree of cigarette smoking in your patient. Assess for a family history of colon cancer. Before surgery, focus on the preoperative care and what the patient needs to be taught. In an ostomy procedure, an abdominal incision is made and either the colon, known as a colostomy, or the ileum, known as an ileostomy, will be brought to the outside to drain fecal material. A colostomy may be required after a colectomy. Colostomies are identified by their location and whether 1 or 2 lumens are visible. Transverse colostomies can be a loop colostomy or a double-barreled colostomy. Sigmoid colostomies colostomies are the most common location. For a loop colostomy, during surgery, a loop of the colon will be brought through an abdominal incision and onto the surface of the body. An appliance for the collection of fecal matter will be attached over the entire exposed colon. In a double-barreled colostomy, there are two separate stomas. The loop of the intestine will be completely severed, creating a proximal stoma and a distal stoma. The distance between these stomas will vary. If they are too close together, it will be difficult to get a good seal for the collection device around each one. Eventually, the ends of the colon will be reattached. There is only one stoma in a single-barreled colostomy. The end will be brought to the abdominal surface, effaced, which means cuffed over itself, and then sutured into the skin, making what is called a surgically mature stoma. An ascending colostomy is one in which either one or a loop of the portion of the ascending colon is brought to the surface of the abdomen to form a stoma. The stool from an ascending colostomy is watery and unformed. An ascending colostomy is typically temporary, and it will be performed to allow the bowel distal to the ostomy to rest and heal. A transverse colostomy is situated towards the middle of the abdomen. This is the location of the transverse colon. This type of colostomy is typically temporary. The stool from a transverse colostomy will be soft and discharged unpredictably. A sigmoid or descending colostomy is located on the surface of the lower quadrant of the abdomen. This is the most common type of permanent colostomy and is typically done to treat cancer of the rectum. The stool from a sigmoid colostomy is more solid and well formed. It may be discharged no more often than once a day or every 2 days. These images can be seen on page 705. An ileostomy is performed to drain fecal material from the ileum. This is indicated when disease, congenital defects, or trauma requires bypassing the entire colon. The stool from an ileostomy is liquid, and although digestion is completed by the time the fecal material reaches the stoma, it still contains digestive enzymes that are highly irritating to the skin. Skin protection is therefore very important for long-term management. The pouch ileostomy or continent ileostomy will free the ileostomy patient from the need to wear a collection device. The patient will then empty their pouch every 3 to 4 hours during the day by inserting a catheter into the stoma. Among those who are not good candidates for a continent ileostomy would include patients with chronic inflammatory disease, because these diseases will tend to recur. Another consideration will be the patient's potential for self-care. The preferred procedure for UC is the creation of a pouch from the terminal ileum. The pouch is then sutured directly to the anus, known as an ilioanal pouch. The anal sphincter is left intact and functional. These patients will then have 3 to 8 bowel movements a day. This procedure will be performed only on patients younger than 55 who do not have any anal sphincter deterioration. These images can be seen on page 706. Before surgery of the large intestine, fecal material will be removed from the colon. To accomplish this, the patient typically takes oral laxatives the night before surgery and then ingests only clear liquids. The contents of the stomach will be removed by inserting an NG tube and connecting the tube to a suction apparatus in the operating room. The immediate postoperative care for a patient who has had intestinal surgery is the same for other patients who have had major abdominal surgery. The patient will be assessed for nausea and treated in the early postoperative period because vomiting will place a strain on suture lines. Pain is typically managed by opioid medications that do contribute to decreased bowel motility. Early feeding will encourage peristaltis in the gut and decrease ileus. The passage of gas, liquids, or solids through the rectum or through the stoma is an indication of active peristaltis. Pain assessment should be ongoing, and the effectiveness of analgesia should be assessed after administering pain medication. The stoma is inspected for a normal pink or deep red color, which indicates adequate blood supply. It should look like a healthy mucous membrane, like that inside the mouth. Anything more than slight bleeding around the stoma should be reported. A dark purple or black stoma color should be reported immediately. The skin around the stoma will be assessed for irritation or signs of breakdown. In the early postoperative period, the stoma will be slightly edematous and larger than it will be after complete healing has taken place. The opening of the collection device should be at least 1/8 of an inch larger than the circumference of the stoma. Fecal output from the colostomy stoma will not occur for 2 to 4 days due to the preoperative bowel evacuation, possible ileus, and the clear liquid diet ordered postoperatively. Initially, there will be a drain in the wound. Antibiotic therapy will be given for 24 hours postoperatively for antimicrobial prophylaxis or longer if there is a known infection. A surgical dressing should never be placed over an ileal stoma because the output is continuous. If there is a significant decrease in ileal output accompanied by stomach cramping, the ileum may be obstructed. These symptoms should be reported to the surgeon immediately. Accurate recording of intake and output is especially important in the care of an ostomy patient. Total output of fecal material should be calculated every 8 hours. When the patient's condition is stable, ostomy output will be regular and the patient's nutrition and hydration status are normal. Then intake and output recording can be discontinued. A patient who has had an ileostomy must always be watched for signs of dehydration and fluid imbalance. Therefore, fluid intake should be sufficient to compensate for the loss of fluid through the feces. Once the patient is eating again, ileostomy drainage will typically be emptied 5 to 8 times per day. The pouch should be emptied when it is 1/3 full. A continent ileostomy with a cock pouch has a drainage tube inserted, with gravity drainage maintained in the immediate postoperative period to prevent distension and allow the pouch to heal. In about 2 weeks, the patient will be taught to insert a catheter into the pouch to drain its contents. As the pouch matures and its capacity increases, the time between drainings will lengthen. The pouch can be irrigated occasionally to remove any fecal residue. The patient will not have to wear a collection device with this type of pouch. Sigmoid colostomies will require irrigation. This can give the patient some control over when the elimination will take place. This procedure can be done daily or every other day at about the same time, and it does take close to an hour. If the patient has a regular evacuation pattern, irrigation will not be necessary. The major reason for irrigating a colostomy is to establish a pattern of predictable bowel movements at the patient's convenience. Drainage from an ileostomy will contain enzymes and bile salts that are highly damaging to the skin. The 2 major principles to follow to protect the skin are cleanliness and the provision of a protective barrier to prevent contact between the skin and discharge from the stoma. Appliances are generally changed every 2 to 3 days to maintain an effective seal. When the appliance is changed, it must be removed carefully and the skin then washed gently with soap and water so that the skin is not damaged by vigorous rubbing or scrubbing. The area should be rinsed thoroughly and dried by patting, not rubbing the skin. After cleansing, a protective skin barrier paste, wipe, or spray, which will serve to prevent contact between the skin and the waste being discharged through the stoma, will be applied. The enterostomal therapist or surgeon will usually indicate which type of barrier is the most effective for the individual patient. There are 2 kinds of pouches or appliances, the drainable and closed end. Each one will be attached to a faceplate that is secured to the skin around the stoma with a special adhesive. Barriers or wafers are also available in pre-cut and moldable options. Your attitude towards the patient, the stoma, and care will have a major effect on the attitude that the patient develops about their body image changes and their own self-care. A matter-of-fact, efficient approach will be best when caring for the stoma, the effluent, and the drainage device. It's important to provide emotional support. As soon as postoperative pain is well controlled, it would be best if the patient could talk with another patient who has fully adjusted to their ostomy and is now living a full and active lifestyle. The patient should be guided to express their concerns about the physical and social problems that they might encounter as a result of the ostomy. Most patients will have concerns about odor, leakage, and noise from the passing of flatus. You and the patient should jointly explore changes in lifestyle and realistic alternatives. You should indicate that concerns about sexual function are expected, and the patient's sexual partner should be included in these discussions. When the patient has prolonged dysfunctional grieving, becomes clinically depressed, or cannot accept their altered body image, referral to a professional counsel may be appropriate. Teach the patient how to control odor. Good basic hygiene will be essential. Another measure to control odor is to eliminate from the diet any foods known to cause odor or gas. Such foods would include eggs, fish, garlic, raw onions, cucumbers, radishes, sauerkraut, corn, broccoli, cabbage, cauliflower, asparagus, dairy products, beans and other legumes, soy, some spices, and chewing gum. Gas entering the pouch from the stoma can accumulate there until the pouch is opened and the gas is released. This is called burping the bag. Patients with a colostomy will slowly resume a regular diet. All ostomy patients must be taught how to prevent problems with diarrhea, constipation, and blockage. Hemorrhoids are varicosities of the vein of the rectum. They can be internal, which means they are inside the sphincter muscles of the anus, or external, outside the sphincter muscles. Constipation, obesity, prolonged standing or sitting, and pregnancy are all predisposing causes of hemorrhoids. Enlargement of the prostate, uterine fibroids, and rectal tumors are other contributing factors. Local pain and itching are the most common symptoms of hemorrhoids. Bleeding from the rectum at the time of defecation can also occur. Hemorrhoidal blood will typically be bright to dark red and will be located on the outside of the stool. Diagnosis is made by physical examination. The symptoms of external hemorrhoids can be relieved by correcting constipation, local applications of heat or cold, and sitz baths. The use of ointments that contain a local anesthetic will help relieve itching and pain. Hydrocortisone ointment and suppositories can help decrease the swelling. A high fiber diet and adequate fluid intake can help decrease or eliminate symptoms. Hemorrhoids that do not respond to conservative therapy can be treated by scleropathy. This is injection of a solution that causes the vessel to dry up and disintegrate. Cryotherapy, which is freezing, photocoagulation, which is burning, or infrared coagulation, known as IRC. A hemorrhoidectomy using a laser or standard surgical procedure could also be performed. Preoperatively, you must instruct the patient on rectal hygiene and the use of hydrocortisone suppositories or cream, as well as sitz bath to decrease the swelling. After surgery, the patient will receive a prescription for analgesics. An air-filled or foam pillow can be used while the patient is sitting to decrease any pain and pressure on the rectal area. Bowel movements after a hemorrhoidectomy will cause some pain, and the standard procedure is to administer a stool softener to make this defecation less traumatic. A sitz bath after each bowel movement can offer relief and also cleanse the affected area, keeping it free from irritation. The word pilonidal means having a nest of hair. A pilonidal cyst is a lesion located in the cleft of the buttocks at the sacrococcygeal region. This is sometimes called a pilonidal cyst, but it is believed to be a subcutaneous canal with one or more openings into the skin, rather than a true cyst or fluid-filled sac. Factors that can lead to the development of such a sinus include local injury, improper cleaning of the area, and obesity. A pilonidal sinus may cause no trouble until it becomes infected, and then the patient experiences pain in the area, with swelling and a purulent drainage. Diagnosis is made by history and examination. Mild to severe pain with a sudden onset while sitting or bending indicates an acute flare-up and possible formation of an abscess. When symptoms are severe or persistent, with abscess formation, the area must then be incised surgically and the connecting canals opened and drained. Packing will be left in the cavity so that drainage can continue. Postoperative care will include removal of wound packing, cleansing with warm water 2 to 3 times per day, and redressing the wound. Good hygiene and shaving the site every few weeks can prevent future infections. Antibiotics will not heal a pilonidal cyst. An abscess can form where there has been irritation with breaks of the skin or mucosa. Tears in the mucosa of the rectum from hard, constipated stools could predispose to abscess and fistula formation. A discharge of pus from the fistula opening could be the first sign of an abscess or fistula. They will be painful, and sitting or coughing will aggravate this pain. Diagnosis is made by history and physical examination. Medication for pain will be prescribed. Incision and drainage of an abscess may be necessary. A fistula will typically require surgical excision and repair. Sitz baths can be used to decrease inflammation. Nurses in the community should teach self-care and habits that promote a healthy function of the GI system. They should teach about the warning signs of colon cancer and any other appropriate nursing interventions. Nurses should be a role model for a healthy diet and exercise program to maintain their weight within normal limits.